Good evening again. So COVID has created many problems, and one of the side effects has been delays in getting visas. And that is the reason why Dr. Pawar is not here, and I'm presenting on his behalf. So no disclosures. Now, all of us know that COVID does create a hypercoagulable state and has resulted in over 30% of patients in ICUs getting venous thrombosis. The arterial thrombosis was not much paid attention to, but the incidence reported has been from 3.7 to 9.6%. Now, the current study is a multi-center study from 22 centers across India. It's 1 year retrospective data and a 2-month prospective data. They try to identify the risks for poor outcome. While I'm presenting the data, actually, I'm not part of this study. Immediate outcomes, 14-day outcomes, and limb salvage were noted. So these are the centers that participated. And the definitions are fairly standard: limb ischemia, delayed presentation up to 30 days, Rutherford classification, then WHO classification for severity of COVID. And if there was multi-segmental involvement, then the proximal most segment was taken as the site of involvement. Limb salvage or preservation of a functional foot. And then univariate, multivariate analysis and Pearson chi-square test. Adjusted and unadjusted odds ratio were done. Overall, the numbers were small, so statistics were a little difficult to deal with. Predominantly males, up to 71%. 85% of the people were above 45 years of age, 45 to 60 and more than 60. The first wave saw 51% and the second wave saw 49%. And these were the WHO criteria. Non-severe was where the patient did not require any oxygen support or probably not even hospitalization. Severe where oxygen saturation was less than 90. And there were signs of pneumonia, and critical when life support was required. When we look at the WHO classification of disease severity, majority were in the non-severe group, 193, and very few in the severe and critical group. Presentation according to Rutherford ALI class. Again, if we see majority fell into, or let's say the almost equal distribution, 55% were class 2B and 3, and 45% came into class 1 and 2A. Lower limb was involved in majority of the patients, and a very small number had involvement of all 4 limbs. And I'm not sure whether this was really COVID-induced thrombosis or was it sepsis plus inotropes leading to ischemia of all 4 limbs. 33% of the patients were managed medically. Primary amputation was done in 14%, and over 50% had some form of intervention, majority having open surgery. And the immediate outcomes in the same admission, mortality was 9%, limb salvage was 66%, and amputation, whether major or minor, was 24%. And at 14 days, mortality increased to 13%. The limb salvage remained just slightly below the immediate one, 64.5%. Major amputations were 20% and minor 9.7%, and 2.2% were lost to follow-up. Based on WHO classification, 28% were non-severe, 36% were severe, and 59% were critical. If we look at the 14 days, in the non-severe, the mortality and major amputation were 33%. For the severe, they were 56%, and for the critical, 89%. They combined death and amputation to sort of get a better handle on these statistics. If we look at class of acute limb ischemia, then death and amputation were obviously highest in the class 3. At 14 days, it remained the same, highest in class 3 and 9.3% in class 1. Type of management, medical management saw 23% mortality, surgical 1.7 and endovascular 4.1. And this may have something to do with patients who were extremely ill were not subjected to any procedure, and that is possibly why the mortality was high. Again, if we look at 14 days, the numbers remain similar. Study conclusions: mortality rate was 13% lower than the available literature, included only peripheral arterial thrombosis. Limb salvage rate is 64.5%, which is lower than the available literature. 23% were class 3, which increased the amputation rates. And I think this was a problem because transport was grossly hampered across the country, and patients were not able to reach for tertiary care. And intervention definitely saves lives and limbs. It's heterogeneous data, mainly retrospective, and different centers, they did not have a set protocol. Hospital staff were obviously overwhelmed, and delayed presentations, delay in referrals, and scarcity of vascular surgery units. Thank you very much.